Hello, welcome to Lactation Education for Healthcare Providers. This module is medication for lactating mothers. My name is Kara Rick. I am a Doctor of Nursing Practice student at Arizona State University. I am a certified lactation educator. I'm also a La Leche League leader, and I have a keen interest in breastfeeding medicine and providing support for mother-baby dyads.
And my name is Dr. Rachel Cabrera Dethridge. I'm a family practice physician, and I work with Honor Health in Phoenix. I'm a graduate of Banner Good Samaritan Medical Center, now Banner University Medical Center. And I have an interest in breastfeeding medicine, and I'm a certified breastfeeding specialist.
Objectives for this module are to describe resources on determining the safety of medication used by lactating mothers, to describe the process of medication synthesis in the lactating mother and list variables that would cause a medication to be contraindicated for breastfeeding, to accurately identify appropriate methods of birth control and when to prescribe them to the lactating mother, and to accurately identify appropriate treatment for postpartum depression in the lactating mother. So let's get started. First, we're going to talk about factors that affect passage of medication to the breast milk.
So you're going to see quite a few things on the screen here, and these are all factors that we need to think about when assigning a risk level to drugs for mothers who are lactating and or pregnant. So the absorption rate, dissociation content, volume of distribution, these things have to do with how the drug is going to be absorbed into the mother's body and where they go into the body. The absorption rate is mainly to do with how fast you will get a peak level in your body. So things that impact absorption rate may be taking the medicine with food or not food, and again, pregnancy status, as many women do continue to breastfeed while pregnant as well. The half-life and peak serum time. The half-life is very important in terms of clearance of the drug, and this is what you're mostly going to see on the resources that we'll talk about. The half-life of a drug is the time that it takes to get to 50% of the drug in the body total. This is a constant per drug. It takes about 4 half-lives for a drug to be completely eliminated from someone's body. And so when you're talking about safety of a drug, those two numbers are very important for mothers to start to understand when the drug is out of their system. Dissociation content is sometimes more to do with the ionization of a drug. Drugs that are more ionized or have a positive or a negative charge rather than being neutral, non-ionized. So the ionized ones pass more readily into the breast milk when we talk about the blood-milk barrier. The volume of distribution has to do with where the drug lives in the mother. So is that in the serum, or the plasma, or is it in the tissues? And different drugs have those for different reasons. Molecular size is important because just like the placental barrier, larger compounds have a harder time going through the blood-milk barrier, so a larger compound, the better. So again, the molecular size, the greater, the better. The degree of ionization, more to do again with the dissociation content, as well as the pH factors there. More ionized, positively ionized things are often of a lower pH depending on the compound. The solubility of the drug itself in water or lipids, again, is important because things that are lipophilic are going to pass into the milk more readily than if they're not lipophilic. And binding to plasma protein is very important. If you are bound to plasma, then you're going to have a harder time passing into the milk. So those are all important things. Now, that's how it gets into the milk. What about the dose that the infant receives? It's a product of the serum concentration and how much is getting into the milk, and how much milk the infant is actually taking in, which is going to be determined by how much milk you're making, or your milk yield. Are you having colostrum now, mature milk? The concentration in the milk was the original parameters, and how well the breast is being emptied by the infant and at the previous feeding. The infant's ability to process the drug is determined by several factors inherent to the baby. The processing of the liver of the baby, if the baby has any kidney problems or not, all of those factors. And of course the age of the baby being the most important for detoxification and for excretion.
Perfect. So just to give you an idea, we have a graphic here that shows you what happens when a mother takes in the drug. The drug enters into the mother's blood, then enters into the mother's milk, goes into the infant's digestive tract, infant's blood effects on the infant. There are several different factors that affect this process as we go through. So if you look at the right of this graphic here, you see that when we start with mother ingesting the drug, we talk about bioavailability, distribution, metabolism, and excretion. Going into the mother's blood, when we talk about processing with the kidneys and the liver, the molecular size, the plasma protein binding, fat solubility, acid-base concentrations. This then talks about going into the mother's milk. And this is you think about a gradient. So the drug will go into the mother's milk, and it can come out of the mother's milk depending on half-life and other factors, and ingestion of the volume of the mother's milk. So then we talk about the baby breastfeeding from the mother. How much milk is she ingesting from the mother? What time frame after the mother took the drug, considering the half-life of the drug. Then we look at the infant's digestive tract, like how mature is the digestive tract, distribution, metabolism, and excretion in the infant. A younger infant is going to have slower metabolism. Excretion is going to be a little bit different. An older child will be able to metabolize the drug better because their organs are more mature. Then we look at talking about the infant's blood. Does the infant have any health conditions? Is the infant well? Is the infant sick? And how is this going to, once it enters in the infant's blood, what are the factors that would ultimately affect the infant, and how much of this medication is in the blood? Then we actually talk about effects on the infant and how it would affect the infant. So here we have a diagram that you can think about with your patients. And I'm going to provide a copy of this in the resource section of this module so that you can print it off and have it in your practice for making decisions for providing medication to mothers. So we think, okay, is this patient breastfeeding? We're talking through this one. Yes, the mother is breastfeeding. Is the prescription necessary at this time? Sometimes the mother can get by without having a prescription. How necessary is it for the mother's condition that we are trying to treat? So if a mother definitely needs a prescription, we go to several resources, which I'm going to list on the next slide, that talk about first choices of medication and if they're compatible with breastfeeding. If we're not sure, again, we look at the resources. You may already have knowledge ahead of time, but the one thing that I want you to remember is that there are resources out there for you to consider, so please don't always tell a mother that she needs to pump and dump, that she needs to wean her baby, that she can no longer breastfeed, because the resources that are out there, the research is out there. Utilize the knowledge that is available.
And the reality is that even though mothers are going to need some sort of medication at some point in their lives, whether they're lactating or not, or whether they're pregnant or not, there are safe medications that they can use during lactation. We should not leave them without treatment, without care, and also we should not impact their goals in breastfeeding.
Yes, so making sure you're having these conversations with mothers about a medication you're choosing, why you're choosing it, and how it is going to affect her breastfeeding relationship with her baby. So here's a list of some excellent resources that you should utilize in your practice for determining medication compatibility with breastfeeding. First is a book by Dr. Thomas Hales, Medication and Mother's Milk. You can buy this on Amazon.com for about $30, so it's really actually very reasonable. And Dr. Hales updates this book every 2 years, so you could even find an earlier edition for much cheaper that you could have in your practice. And whenever you're prescribing a medication, go to it to see what the research is saying and what the level that Dr. Hales gives it in terms of compatibility with breastfeeding. Two other resources that are available on the internet are ToxNet, LacMed, and Lactating, and the web addresses are here, and I will also provide web addresses in the resource section. You simply go there, you type in the medication you're looking for, and it gives you all of the research that's available, and also gives you alternatives. So if this medication may not be compatible with breastfeeding, it will list other medications within those categories that may indeed be compatible for breastfeeding.
The other great thing about this is it takes all of those parameters that we talked about before, and they have rated them for you. You still can go and look those up yourself, but it's nice to know that they took those things into account when making these things. One other thing I want to mention is pay attention to your medication formulation, because depending on whether it's a salt like a hydrochloric on the end or some other substrate on there to make it a long-acting will impact its rating.
Yes, two other resources I want to mention are MicroMedMex and the Infant Risk App. The Infant Risk App is actually done by Dr. Thomas Hales, and you can download that onto your phone, and you can have that available when you are in clinic if you don't have Dr. Hale's book to look up for medication and its compatibility with breastfeeding. Now we want to go in and talk about some specific issues relating to breastfeeding and medication management. So 2 things that we know about with mothers who are breastfeeding after giving birth are contraception, and the second thing we will talk about is the treatment of depression. So first, with the contraception. Information we are giving you here today comes from the Academy of Breastfeeding Medicine Contraception Protocol. I have put a copy of this protocol in the resource section so that you can download a copy. You can keep a copy in your practice. This particular protocol was updated this year in 2015. Remember that you can go to the Academy of Breastfeeding Medicine website. They have over 20 protocols listed for treatment of lactating mothers for various conditions. This is protocol number 13. Go there often. They update these protocols quite often, and make sure you're using the best evidence-based research when you are prescribing and talking with your patients. So types of contraception that we're going to talk about: lactational amenorrhea method, natural family planning method, barrier methods, intrauterine devices, sterilization, progesterone-only hormone options, estrogen-containing combined hormonal options, and emergency contraceptives. We will start off with lactational amenorrhea method.
So this is a method that many breastfeeding mothers are using and they don't even know it. So lactational amenorrhea, what is it? It is defined by 3 things. First, are you having a period? Meaning, have your normal menses returned? To have normal menses, that needs to be more than 2 days of bleeding, or 2 or more days of bleeding. And it has to be after the time postpartum when you are having your lochia, which is the postpartum bleeding. So 1, are you amenorrhea? Good, so you are. 2, are you fully or almost fully breastfeeding? What is almost fully breastfeeding? That's not missing more than 2 per week sessions of breastfeeding. So if you are feeding on demand, not on a schedule, but on demand for your infant, and that you are almost fully breastfeeding or fully breastfeeding, you've met the first 2 criteria. Number 3, is your baby less than 6 months old? Easy question. So if your baby is less than 6 months old, your periods have not returned, and you're fully breastfeeding on demand, then you meet criteria for lactational amenorrhea. What does that mean? That means that you're probably not ovulating because of your body's hormonal status and the hormonal status that the breastfeeding keeps in you. So this has been evaluated multiple times, and pregnancy rates up to 6 months have been between anywhere from 0.45% to 2.45%. So 97+% effective if you're meeting those 3 criteria. When we get into problems is when people are not meeting that criteria, if they're giving bottles or other things more often.
So when you're talking with a mother who's breastfeeding, who may have newly had a baby, mentioning this method is quite appropriate because the Cochrane literature review is there. The evidence suggests that lactational amenorrhea is ineffective if you are meeting those 3 criteria. Also, it's important that mothers are aware of the 3 criteria and how they might be able to get pregnant. And so counseling plays a huge role in this to be effective, and mothers being aware of her body.
If you're a pregnancy provider, prenatal provider, or if, let's say, you're the child's provider and the mother is pregnant, you can also bring this up with them, because in the postpartum room, in the postpartum suite, is a terrible place to talk about anything. It's very hard to remember, and so addressing this early on, and all contraception things early on, is so important.
Yes, so having these conversations about contraception before a baby is born can be very beneficial to mom to preserving her milk supply. So here we have a chart talking about natural family and lactational amenorrhea method, talking about the advantages, the disadvantages, and the effects on the breastfeeding relationship.
Just as a side note, we didn't go into depth about natural family planning, but there's a lot of resources describing natural family planning, and that is a little bit more time intensive, but it tracks different things. One may be your basal body temperature or your cervical mucus, or by dating of your last menstrual period. And then we did talk about the lactational amenorrhea. So the advantages of natural family planning and lactational amenorrhea are that, one, there's no hormonal side effect or medication side effect because you are not putting a medication or a substance in your body for that. The effectiveness rates are comparable with other methods of birth control, not necessarily superior, but comparable. And they are low cost for both of those methods, of course, unless you're using some sort of fertility monitor. That may be a cost to you, but certainly not compared to other forms of hormonal birth control. Disadvantages are that they do require special instructions and for patients to understand those instructions completely. And again, if you're buying a monitor, that may be a disadvantage for an expense. And many times there are long periods of abstinence that are required, specifically with the natural family planning method.
So counseling, talking to parents about families, about advantages, disadvantages, and making sure they're well aware of what's required if they're going to use lactation, amenorrhea method, or natural family planning. Next, we're going to talk about barrier methods. So when we think about barrier methods, we think about condoms, we think about diaphragms, and we also think about spermicide or anything else that prevents the sperm from getting to the egg that is not hormonally related.
So barrier methods have been used for a long time, and they've been used successfully for a long time. And there's certainly going to be those patients who still want to use those methods. So some of the advantages, again, there's not going to be as many side effects from medication side effects, although you may have contact allergy side effects for some people. They are effective as long as you're using them diligently and they're sized appropriately. For example, the cervical cap must be sized in order to be used. They're very easily accessible. They can be used as backup methods if somebody's using, for example, a natural family planning method and they're close to the days where they may be fertile. This is a good backup for them. These are also very low cost because you just use them when you need them, and they provide, some of them provide protection against sexually transmitted infection, particularly the condoms. So that's important for many people. There is some potential for error, of course, with any of these, and as we already addressed, there's some contact allergy that can happen. They may be limited in certain relationships because one partner may not like them or it's not spontaneous enough for some person, and so it's very important to talk to your patients about their sexual habits and their desires in addition to what we're talking about today. The effects to breastfeeding, again, are none because we're not using a hormonal method that may impact the breast milk production. Lubricant, as a side note, as you see there, can be used with condoms, of course, and there's also lubricants that come in condoms as well.
Next method we're going to talk about are the IUDs, and there are two that are available on the market, I guess technically three. There is the copper IUD, the Paragard, and there's also the progesterone IUD, which is the Skyla.
There's the Skyla, Alaletta, and the Mirena.
Skyla and Mirena, and all of those are effective for different periods of time when placed in the woman's uterus. The important thing I want to talk about before we go with advantages and disadvantages is that typically we do not place IUDs in women until 6 weeks after post-delivery. There is some research that talks about putting them in 48 hours after post-delivery, so if an IUD is an option that you are going to choose, it's important that you have another method or think about lactational amenorrhea or barrier methods before we can insert the IUD.
And especially knowing that many women who are breastfeeding are already going to be amenorrheic, lactational amenorrheic anyway, it is safe in most cases to wait the 6 weeks to put them, to insert them for women. And again, you just need to have a good, clear understanding with your patient.
Make sure mom is breastfeeding on demand.
Mm-hmm. And if she's not, condoms.
Yes.
Now, when you're counseling your patients about IUDs in particular, there's many advantages. They're highly effective. It's very hard to have user error with an IUD, which is so important. They're still reversible. There's nothing permanent about this. You can use it for long-term contraception. And again, because it's very hard to not use an IUD correctly, little user attention is required. Now, in the office setting, of course, depending on your practice and how you manage your IUDs, You may have women check, you may have them look for strings or return, and those are different things. There's more of a style for providers, but very effective, very easy for the patients to use. The disadvantages, they're mainly when you place the IUD. So you should have an experienced provider place the IUD. Family practice also inserts IUDs, OB-GYNs, and some other offices, and I believe some pediatricians as well, if they're doing more teen medicine, can do those as well. So small risk of infection and perforation and expulsion. So the IUD, yes, it may fall out, but that's why we have women check. The risk of infection and perforation is extremely low, and actually is more of a risk when the uterus is not contracted down as it should be. And so waiting that 6 weeks again is not unhelpful. It's actually very helpful for the IUD placement. So a disadvantage, yes, it requires a provider. If you're using it for only the short term, then it does not become very cost effective. But the high cost of an IUD, of the old IUDs, especially the Mirena and the Paragard, is offset by how long they can be used. So effects relating to breastfeeding, the copper IUD, we have here, there's no known impact. That would be on breast milk supply. Certainly some women have some more heavy bleeding with the copper IUDs, and so if anemia is an issue for your patient or prior heavy bleeding is an issue for your patient, that may actually impact breastfeeding just on a volume standpoint. When we're volume depleted, we don't make as much breast milk in some women. The levonorgestrel is the progestin in the Mirena and the Skyla, and I believe it's called the Liletta. That particular medication, since it's placed directly in the uterus, there's a low concentration in the bloodstream, and it does not seem to have an impact in breastfeeding. There's been some reports of maybe a little bit less of production, but certainly nothing compared to other hormonal methods.
So let's talk about progestin-only hormonal options. And there are a couple here that we're going to talk about. There's the pill. There's the Nexplanon, which is the implant that we put into the arm. And there's the Depo-Provera shot. And so a couple things that we want to talk about is that Depo-Provera, if we are giving it right after a mother has given birth, can have extremely negative impacts on her breast milk production and lead to low milk supplies in the future. The one, we're going to talk about this more with effects on breastfeeding, but something that I want you to be mindful of even now before we go into this is that if we use something like Depo-Provera, because it is an injection, it goes into the blood, we can't take it away. So talking about advantages of progestin-only hormonal options. There are long-term options that are highly reliable. We talked a little bit about the IUD before, and also the Nexplanon that is put into the arm. Disadvantage that we talk about are irregular bleeding, and it may be very problematic for breastfeeding mothers because she may not, mother may not know what's going on with her body, why she's having this bleeding, what's going on. And it can be a little bit scary if you have a new infant at home, your body isn't working in the same way that it's used to working. There's potential for failure with daily use. If we are prescribing progestin birth control pills, then we know that, with having a new baby, mommy brain fog may not always take the pill on time, could possibly lead to a pregnancy if mom isn't breastfeeding on demand. Going back talking about lactational amenorrhea, and the body already has the hormones in place because mom is breastfeeding. Might not be such an issue, but then we start to consider why are we prescribing the birth control in the first place. Mm-hmm. Other side effects from progestin only: headache, acne, weight gain, bloating, depressed mood. Again, like we talked about the Depo-Provera, if we give the injection, after the woman receives the injection, she has a delayed return to fertility. We know that Depo-Provera is good for a 12-week period. That doesn't necessarily mean after 12 weeks a woman will become pregnant. If she's wanting to become pregnant right away, it's important to have these conversations with her. The implant and the IUD, as we talked about before, require insertion and require removal. So talking about effects relating to breastfeeding, there is a theoretical potential to adversely impact the milk supply when we use progestin-only hormonal options before there is established milk supply. So we are talking about the period between birth and 6 weeks. If we are to prescribe these medications, the research is telling us that the mother does not develop her full milk potential because progestin is a hormone. So we think about the hormones that affect breastfeeding, and progestin, prolactin, estrogen, all have effects on breastfeeding. And so progestin actually drops when the woman expels the uterus, and that allows the milk supply to come in. So if we are reintroducing this progestin at a time before that full milk supply is in, the body becomes confused, the milk supply doesn't fully develop, and this then has negative effects on mom and on baby, because if mom isn't aware that she's going to have low milk supply, baby can have potential negative side effects from that, and it can lead to problems.
So with the progestin-only hormonal options, be it the IUD or the Nexplanon or long-term options, if there's a question and mom is concerned about her breast milk supply, and let's say she's already using condoms but she wants to switch to a hormonal method, the progesterone-only pill, if used not as the primary method but as a backup method, if she's using condoms, is a great way to kind of test out how she would do with the progestin. So if she has very erratic bleeding with that, she may not want to actually have one of those progestin options as soon. If she does really well with that, she might feel a little bit more reassured.
Right, so if you are considering something like the Nexplanon and IUD, certainly could start with a mini pill supply for mom to see how she reacts to it before we go in, and we talk about cost effectiveness before we spend the money to insert the IUD, to insert the Nexplanon, because if it's not working, obviously we have to remove this from the mother, because she either may have negative side effects for her body, or it may have a negative side effect for the breast milk production. Talking about estrogen-containing combined hormonal options. So we know there are multiple pills on the market that are estrogen and progesterone. There's also the Ortho-Evra patch, and there's also the NuvaRing that are currently available in the U.S. market.
Okay, so estrogen-containing combined hormonal contraceptives, this is what you would normally consider the pill, not the mini pill, which is often just progestin only, but combined estrogen-progesterone hormonal options come in very different flavors, right? So all of these are so much lower in dose than they used to be years ago, and many of the side effects of the systemic side effects are improved. Breastfeeding is a specific time for a woman and a specific hormonal balance, and so we want to give special attention to these. So great things about the pill is that it can be taken at home. They don't have to come to the provider's office every 3 months for an injection. They have regular menstrual cycles, which many women love, and there's also other regular menstrual cycles that are extended, that are still regular, such as 3 or 4 times a year. There's the non-contraceptive benefits for women who, for example, have acne, or who suffer from menorrhagia and have anemia, or who have very painful periods. Unfortunately, there's still some room for user error if we combine that if we look at that versus the long-term contraceptives. There's an increased risk of blood clots with all of these, but certainly with Ortho-Evra more than the others. There's potential for drug-drug interactions with any medication, especially any oral medication, which this is. And there's multiple medical contraindications, as we all know, such as smoking over the age of 35. So in breastfeeding, it would be best to wait until probably minimum 6 months. Can these be started earlier? Sure, they can. Hopefully not before 6 to 12 weeks. That would be the lowest limit. But certainly the establishment of the milk supply before that time is so important to preserve. There's potential for adverse effects I'm repeating myself. So waiting till milk is well established, 6 to 12 weeks. Newer information is indicating that may extend out to 6 months. That's why, again, if there's the option not to start until 6 months, delay until 6 months, when complementary foods can then be started as well to make up for some of the dip in the supply. Again, when you're counseling a breastfeeding mother, make sure she understands that there will most likely be some dip in supply. It's impossible to say how much because that is so dependent woman to woman, how often she's breastfeeding. Is the breast being emptied completely? Is she working? Is she pumping? There's just too many factors to say for sure.
We don't go into the hormonal effects of breast milk, like the different hormones that we talk about that play into to making breast milk and making supply, and that's covered in another module. But it's important to know that that breastfeeding and breast milk production is hormone driven, and so when you are thinking about using hormonal contraceptions and adding something more to the body, of course there's going to be side effects to the body that we may or may not intend to introduce. And so when thinking about different birth control options, remember to go back and think about what we are doing to the body, what are we trying to do, and what is the end result we're trying to achieve.
And when we talk about the safety of the medications as well, we've just been talking about the safety in terms of the breast milk supply, but certainly these are safe for the baby themselves. Will they get some dose? Of course they will. They had dose of that while they were in utero, but just for a caveat.
Right, and Dr. Hales, Lactating, all do a great job of addressing the safety of this medication. Most all research says that contraception are extremely safe for breastfeeding. What we are really talking about here is prescribing, thinking about preserving the milk supply, thinking about providing nutrients for the baby, and thinking about the long-term health of mom and baby, because we know that breastfeeding has improved outcomes for mom and for baby. So, moving on, talking about emergency contraceptives. It could be that you don't often use these in your practice, that you don't prescribe them, but I want to touch on them here because there may be a chance that mom was following lactational amenorrhea method, something's gone wrong, something's happened, and just to have a background knowledge of the different pills, how they affect the milk supply, so that you can have these conversations with mom if this situation comes up. Emergency contraceptives that are available on the market: Plan B, LO1, copper IUD is inserted, Prevent are all available on the market at this time. So emergency contraceptives, what are the advantages? We know the research tells us that they are most effective when used within 72 hours of exposure. So if a mom comes into our clinic, she's had unprotected sex, she's worried about pregnancy, we have to get this on board almost immediately. Plan B is progestin-only option, and it seems to be superior to the other options in terms of side effects. The copper IUD is also effective, and the benefit of the copper IUD, if we insert it, is that it's going to provide ongoing protection for mom. So if she is at that point where she, has either had a period, lactational amenorrhea is not working, she has a concern, inserting the copper IUD will continue to protect her. Copper IUDs can be left in for 10 years. Disadvantages to some of the emergency contraceptive options: estrogen-containing option can have very terrible side effects. Nausea and vomiting, oftentimes requires antiemetic. There's not a lot of data that's available for all of the emergency contraceptives and their relation to lactation. So again, going back to the resources that we mentioned at the beginning of this lecture, if you were in a situation where you were prescribing one, you were unsure, certainly go back and look at the research and see what it says about milk supply, health to mom, health to baby. Side effects related to breastfeeding, we've kind of already discussed progestin-only methods, estrogen-containing options, and how it affects the breastfeeding mother. Going back and keeping those ideas in mind, just make sure you're having a meaningful conversation with mom about what her options are and what the outcome could potentially be. And by arming yourself with the knowledge that we are presenting in this module, you will be able to have a meaningful conversation, and your patients are going to appreciate you more because of it. They want this information, and they want to make an informed decision about their contraceptive options and how it is ultimately going to affect their milk supply, affect birth control for the future, affect family planning. So on the last slide here, I have a diagram that is taken from the Academy of Breastfeeding Medicine protocol that you can download from this module and talks about the rankings from the World Health Organization and from the CDC. And this mostly goes over the same information that we have gone over. The World Health Organization gives rankings for oral contraceptive, progestin only, the IUD, and the IUD, so that you can look on here, just as we've described, the estrogen birth control pill receives a level of 4, which means really not ideal, should not be prescribed in the first 6 weeks for breastfeeding. Even in 6 weeks to 6 months, not ideal because there are so many that are seen with a decrease in milk supply. Progestin only, 0 to 6 weeks is given a 3, but then once we get past the 6 weeks, it gives it a rank of 1. The IUDs, again, we talked about inserting after 6 weeks when the uterus has involuted and gone back to its normal size. The World Health Organization and CDC have similar recommendations that we have already discussed. As we've discussed, counsel families, protect a supply, feed the baby. Knowing the information we've given you, information continues to evolve. There's research that goes on in this area of contraception and breastfeeding. Keep up to date on it. Make sure you're having meaningful conversations with families. Make sure you're preserving the milk supply, especially if that's what the mom is trying to do. Next thing we're going to move on and talk about is treating depression in lactating mothers. And there's 2 things that we want to keep in mind here, that some mothers may come to your practice and have had depression either before they've become pregnant, during their pregnancy, and then some develop postpartum depression that we know of. And so this discussion talks about mostly treating postpartum depression, but the information we give you can be very beneficial for treating mothers who are in pregnancy. And again, going back to the resources that we provided you, the Hales book, Elactina, and Lactmed. The Academy of Breastfeeding Medicine also has an excellent protocol talking about use of antidepressants in breastfeeding mothers, protocol number 18. The next slides that I'm going to show you actually are pulled from this protocol. You can download this protocol in the resource section, have it for your records, go back and check often for updated information. So we talk about screening for the breastfeeding mother, and screening has become quite commonplace in our culture. Oftentimes, a mother will be screened at her first postpartum appointment, and oftentimes pediatricians are screening for depression at baby's 6-week well baby check. The most common scale that we are seeing used is the Edinburgh Postnatal Depression Scale. There are a couple others out there. The evidence supports their use. In your practice, pick one that works, make sure you're utilizing it, make sure you're checking mothers for depression, because oftentimes as practitioners we don't have these conversations with moms, but they really need to be had.
And I would say standardize it. Standardize it in your office of, if you're somebody who treats children at their 2-week visit or their 4-week visit or their 6-week visit or their 2-month visit even, make sure that at some point you're screening these moms. And then for somebody who provides care for the mother, again, just standardize. Sometimes these moms come in before their official postpartum visit for something else, a cold or something else, or poor sleep. Screen them then, don't wait.
So screening and follow-up care through 12 months. So if you get a mom that has a positive screen, you want to continue to follow up with her, continue to use screenings, continue to check for postpartum depression. Postpartum depression does not occur right away, and it can occur at any point after the baby is born. It affects both the child, the partner, and other family members. Women who experience breastfeeding difficulties are much more likely to have depression at 2 months than mothers who are not. And a lot of that goes to emotional feeling like she can't feed her baby, feeling she cannot take care of her baby. And so this particular population is especially important that we talk to them and screen them for depression. We also know, and the research also tells us, that breastfeeding experiences and supporting breastfeeding are very, very helpful in supporting postpartum depression. So we often find if a mother is having breastfeeding difficulties and we are able to resolve those difficulties, that her depression a lot of times goes away, because there are these hormones, oxytocin, in the body that we kind of call it the happy hormone, can help to improve mother's mood, to improve their energy levels, and to make them feel better. So treatment options for postpartum depression.
So you don't want to deprive a mother of treatment for postpartum depression, and conversely, you don't want to say you need to stop breastfeeding because you have depression and we need to treat that. So both of those are wrong, and we can treat them together. There's non-pharmacologic and pharmacologic treatment that we can offer mothers. And oftentimes non-pharmacologic is not really used in day-to-day practice because we rely so much on the medications, or the mother may come in with such a severe depression that you feel that it's indicated to start a medication right then. But knowing our non-pharmacologic options is so important to come around mothers, especially who are breastfeeding. Breastfeeding mothers oftentimes are more receptive to non-pharmacologic things as well. So perhaps you might have experience with patients not wanting to go to psychotherapy. That may not be true in the breastfeeding mother, so offer those things. So one method would be the psychological therapy, and there's different flavors of that. Most of us are familiar with cognitive behavioral therapy, there's interpersonal therapy, there's other forms of therapy that can be used. Even depending on the type of depression, bright light therapy may be used. Certainly exercise is something that's very important to encourage in your patients and any patient with depression, and making sure that they have a healthier diet in general. So next, under non-pharmacologic, is also infant feeding considerations. So if the infant is not feeding well and breastfeeding is not going well, as you saw in the previous slide, these mothers are at higher risk or higher association of being depressed and postpartum depression. So being aware of how the infant is feeding, is there pain, does the infant have a poor latch, and listening to your mother about how she feels about feeding her baby is a big clue to whether it's time to involve an IBCLC or to consult somebody who has more experience than yourself, or just to refresh on what you've already learned and put that into practice. So what we'll talk about upcoming is different medications that are used to treat depression, because certainly it is not contraindicated to treat depression medically while breastfeeding.
Right, if you have a mother who's breastfeeding, comes in for depression, you want to continue to encourage her to breastfeeding, and you also want to provide medication. As we've talked about the resources that I listed at the beginning of the slide, we will discuss medications that are perfectly appropriate for breastfeeding mothers to help with their depression. So prescribing medication in mothers who come to you and have depression, and we have screened them as positive. The most common class that we talk about is SSRIs. Citalopram, fluoxetine, serotonin, paroxetine. On this graphic here, we see the different drugs, we see the different doses, and the different indications. Maternal side effects that we see, these are all research-based, and then effects on the infant. And when you are prescribing a medication, and we talked about in the beginning the different mechanisms that affect medication going into the breast milk and infant receiving the medication, you want to keep this all in mind. There are a couple of medications that have been more well studied and that are highly recommended in the SSRI class to be prescribed to mothers who are experiencing postpartum depression.
So in general with the SSRIs, the most I shouldn't say the most well tolerated, a very well tolerated medication is sertraline, and it's very safe to use in lactation as well. People tend to respond to it well, but knowing that even though there's a large population who would benefit from this, not all SSRIs work in all people. And so even though this is a great drug and it's well tolerated, it may not be the drug for your patient. And so if your patient is not responding to the therapy, don't be afraid to try something else in them. Paxil or paroxetine is another option that's well tolerated in lactation and is well studied as well. That being said, the other ones are not completely contraindicated in lactation. Let's say she was treated with fluoxetine, safe in pregnancy. You should have a pretty darn good reason to take her off of that during lactation before switching over simply for lactation risk. Are there some theoretical risks? Sure. Familiarize yourself with the side effects, monitor mommy and baby, and see how they're doing. The majority of the studies for these medications that say if they're safe or not are either going to be based on whether an infant was reported to have some sort of side effect, or based on the percentage dose that the infant had in their serum compared to mom's serum. So that's where this research is coming out of. And of course, in all of these lactation and pregnancy research, you're not going to have randomized controlled trials because nobody's going to sign up for that. So this is the best evidence that we have.
Another one we want to touch on that is actually on the graph here is SNRIs, and I want to point out that one of the side effects that has been noted from SNRIs is galactorrhea. So if you have a breastfeeding mother and she may be having trouble with milk supply and she is experiencing depression, an SNRI might be a good choice because it may help to improve her milk supply. There's not a lot of research that's available, but just because there's not a lot of research does not mean that we shouldn't consider using them. Again, going back to working with the mother, looking at side effects, looking at effects, because the statistics say that typically the first drug we choose to use in any person with depression isn't always the one that works, and so it is necessary to change. So follow up with these mothers, having discussions with them, calling them on the phone to make sure everything is going okay. And if you need to make a change, make a change. If things are going well, awesome.
And just like you would with an Edinburgh Depression Scale, you can use a PHQ-9 or whatever screener to follow them on the medications as well. So there's another class over here that many of us are familiar with tricyclic antidepressants, which surprisingly are also not contraindicated in lactation. And so familiarize yourself, look on your resources again. Nortriptyline seems to be more studied than the others. And yes, there can be potential side effects, but again, monitor your patients. All medications in general for most people, lactating or not, are going to be used the minimum effective dose for the patient for the least amount of time possible that fits into their lifestyle and their budget. The same goes again for lactation, so we're not going to be starting with high doses. Start low, go slow.
Right, so starting at the lowest available. If you need to go up, certainly go up. And having these conversations with mom. How is she feeling? What side effects are she seeing? Is baby tolerating this? Are you noting more sleepiness in baby? Is baby more fussy? This will all kind of give you a clue to how things are going with treatment and if treatment is really going well.
And talk to the psychotherapist who your patient may be working with. Don't leave that as, oh, you see them, now you come see me. Work with them and talk with them if they see that this is improvement on medication or not, because they have some insight that oftentimes we don't as providers.
And also with psychotherapists, make sure that you're talking to them and that they support breastfeeding as well. So we are obviously sending the message that we support breastfeeding, and you want to send mothers to a provider that is going to support breastfeeding as well. Because oftentimes if we tell mothers or give them the idea that they either have to wean their baby, either have to pump and dump, that can lead to greater depression, which is what we don't want to happen. So going on to talking about medication, this slide talks about some natural and herbal medications that we know about, specifically St. John's wort that's used to treat depression. There's not a lot of research that supports this. If you have a mother that comes to you and is wanting to take it or has tried taking it, it's working for her, awesome. Encourage her to continue to stay on this medication. Omega-3 fatty acids is another medication that's in the literature, or herbal that's in the literature that women have been using to treat depression. Not a lot of evidence supports that it is actually treating their depression, but for some mothers, if they are taking this and it is helping, encourage them to continue taking it.
What's been looked at a little bit is specifically the EPA type of omega-3 fatty acid, because they do come in different flavors, but it's the EPA that is thought perhaps to help with depression. Now, again, herbal things, as you can see, still have side effects. So just because it's natural does not mean that it's safe. If you have a mother who's on other medications for other things, I would not recommend St. John's wort, because it does interact with so many other things just of the way that it's metabolized in the body. So just be aware of that. But if you have a mom who's been on this and she's been doing well, again, you have to have a good reason to stop the medication, especially for depression.
Other two medications on this chart for talking about treating disorders and antipsychotic medication. If you are prescribing this for bipolar disorder or for schizophrenia, important to look for sedation in the infant. So if baby is increased sleeping, if baby's not waking for feeding, this becomes a concern, and we need to either look for other medication to treat mom or have the discussion of, cost-benefit analysis for mom and baby. Mood stabilizers, lithium is what we typically see for bipolar disorder. For infants, we see an elevated TSH. Blood levels are typically drawn in the mom. Talking with mom, talking with baby, knowing side effects, knowing cost benefit for mom and baby become really important when talking about using these medications.
Now, this is definitely not a medication that I would start somebody on as a primary care provider, but I would definitely work with the patient's psychotherapist or psychiatrist and talk to them about the risk. And if they don't have the resources to look up what the lactation risk is or the pregnancy risk is, that is your role.
So talking about continuing support and following up with the mother. The biggest thing that you can do is support the mom-baby diet. So having the conversation with mom about what's going on. How are you feeling? How is this working for you? And being there, and also knowing the resources that you can refer mom to if you're not able to provide support in that office. We talk about lactation consultants. If a baby is not draining milk from the breast and you notice that this depression is coming from a feeding problem, certainly utilize an IBCLC and check for other issues that you might be able to help mom and baby with. Another option for just mother-to-mother support, La Leche League is available out there, Breastfeeding USA is out there, and you can refer moms to these places, and they're free community resources. And so sometimes just having support from other moms can make a huge difference in a mother's life, especially if that hasn't been there before.
And I would say, watch the baby feed. If you're a provider who feels comfortable, has some knowledge about that, make it a safe space in your office and have the baby feed there. You'd be surprised how many things that you can pick up right there in the office.
Right. So we another touch on moderate to severe depression may require psychological therapy. We talked about non-pharmacological options and pharmacological options. The treatment, what we know in the literature is that non-pharmacological with pharmacological together results in the best outcomes. And so trying to find that balance with mom, getting her the psychotherapy she needs, getting her on the medication she needs, will ultimately improve the life of that mom, improve the life of that baby, help to preserve that family.
And have that frank discussion with the patient, especially if you feel that this is a moderate to severe depression, of how important it is, because this is talking about actual mortality risk. If a mother became depressed to the point of suicide or to infanticide, which are real things, not to scare a mother, but to completely inform her of what you're talking about and why you are recommending a medication if you are recommending a medication.
Correct. And treatment for mom is individualized. So you may see maybe one mom a week, maybe several moms a day that need treatment. Make sure that the treatment you're prescribing this is specific to that mother. Know what her feelings are, know what her depression level is, and know what she's willing to do. You know, is it important to her to preserve the milk supply? Is breastfeeding important to her? Does she need more support at home? Does she need more support outside the home? Having these conversations can be very beneficial.
And have a close follow-up, especially if you start a medication on someone. For example, when I start sertraline on someone, I may start them at a particular dose and try to titrate them up, but I will see them in 1 week.
And a reassurance, telling mom that this is something that will pass, that we are here to help them and to meet them where they're at, and we want them to get better. We want to preserve the mother-baby relationship. We want to preserve milk supply if that's something that mom wants to do, and we want to help them. We care about our patients, and we want the best for them. Also offering additional resources. I mentioned the Leche League, lactation consultants. All of these different things can have an effect on moms' lives.
And even a myriad of Facebook groups now.
Yes, yes. And other thing you want to do is follow up with infant care providers. So if you are a family practitioner, an OBGYN, make sure that baby's pediatrician knows that you prescribe this medication so that pediatrician can be on the lookout for anything that may affect that baby and the milk supply. Thank you for taking your time to watch this module. This is the conclusion of our module. A list of resources will follow, and if you have any questions or comments, you can follow up with me. Please remember to take the post test for this module so that you can receive CE hours. Thank you.